Good morning, everyone. And or it's on now. It's up, right?
Yes.
Okay. So good morning. Welcome to, this is September, so September's Board of Health meeting. A week from today will be October 1st, so believe it or not, summer's kind of coming to a close and we're almost into colder weather. So with that, we'll go ahead and get started with just the roll call. And I will do that. I think I'm here. So Vice President Doris Ralston.
Here.
And Commissioner Geithner. Lauren, do you know, is she online or? Okay. I suspect she'll be here. Good enough. Commissioner Nelson.
Here.
Mayor Dixon.
Present.
Hunter Barnett.
Present.
Dr. Chan.
Here.
Courtney Salt. Any news? Okay, then maybe they're together. We'll see. And Dr. Vu. Okay, and so they're here. So Commissioner Geithner and Courtney Salt are present. And then Dr. Vu, are you online? I don't see him. Any word? Okay. So we'll see if Dr. Vu logs in or not, but as for now, he's not present. Next item is approval of the agenda. So I would ask for a motion and a second to approve the agenda.
Mayor Dixon, I'll move to approve the agenda.
Doris
Second.
Ralston, second.
Okay, so we have a motion and a second. All those in favor, please say aye.
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 Any opposed? Okay, great. That passes unanimously. And so item number 3 is Board of Health, and we see Dr. Vu is with us also, so that's great. Item 3 is Board of Health comments. I guess we'll just start. We'll start over here since Dr. Vu got here last. Lauren, any comments from you? Okay. Mayor Dixon,
I'll pass.
Dr. Chan.
No comments.
I'll pass over to Doris.
No comments.
Nope. Courtney, Commissioner Geithner, Hunter.
Yep, I'll take a
All right,
minute. I
great.
just want to acknowledge the big news from Secretary Kennedy this week about the potential link between excessive Tylenol use during pregnancy and autism. Would love to hear from our 2 physicians at some point if they have any thoughts on that. For many Americans, hopefully that's welcome news. For many parents, hopefully that's welcome news. So I'm just looking forward to seeing that news develop, more research, and maybe we will have some input on that over the coming months. So just excited to see progress on that front out of DC.
Okay, thank you.
I'd like to weigh in on that very briefly. There has not been any change in the rates of intellectual and developmental disability in the last 60 to 70 years. What there has been is diagnostic displacement. If you look at the rates of what used to be called mental retardation, now is called intellectual disability. But if you encompass autism and intellectual and developmental disability all into one category, all of the overall rate is actually the same. But there's been a displacement of diagnosis. If you change what you call a diagnosis of autism, there's suddenly going to be a higher rate of autism. It's really just what you're calling it. In the 60s or so, autism spectrum wasn't as well recognized. But now a lot of what used to be called mental retardation is now put into the category of autism spectrum disorder because it's a developmental disorder.
Okay, and I think there'll be a lot of news on this over the next few months and at a national level, and we'll see where the evidence shakes out. But Dr. Vu, any comments from you today?
I have heard of that announcement. I have heard the announcement online. I had not previously known of relationship between Tylenol and autism. even though the announcement is that there is a association between Tylenol use and autism, I have not seen that data.
Okay, thank you. All right, if no alibis, we will move on to item number 4, which is approval of the minutes for both August 22nd and the 27th. And are there any corrections to those from board members? If not, then I'd ask for a motion in a second.
So moved.
All right.
For approval.
Second.
Okay, so motion by Hunter Barnett, and the second was by, what, was it by Commissioner Nelson? Okay, thank you. Second by Commissioner Nelson. All those in favor, please say aye.
Aye.
Any opposed? Okay, so that passes unanimously also, and we'll move on to number 5, which is public comment for things not on the agenda. Amanda, is anyone signed up? Okay, anyone in the room wish to make public comment? Then if not, we'll go on to item number 6, which is our financial, the August 2025 financial summary with Lauren Mearmont. So nice to see you again this month, Lauren.
Hi, good morning.
Okay.
I have 2 different presentations for you all today based on our conversation last time about trying to incorporate forecast information and maybe presenting information a little bit differently. The first slide that I have is our traditional presentation that we've been bringing forward to the board for some time, and I just want to call out that the information from this slide and the next slide that are the same is the actual column, so that's our actual to date revenue and expenses, and then our OAB, the changes and revised budget. So those 2 pieces of information will be the same. And what I'd like to do is actually not go through this presentation, but move on to the next. For your information, so we can have discussion about the differences and why I feel like this is a bit more informative for our discussions. So the OAB column is now the first column, same information, that's the originally approved budget for 2025. The changes column is anything that the board has adopted via resolution. Revised budget is the cumulative changes added in. So revised budget is what we're currently working with, and that reflects all grants approved to date for 2025. The actual column is the same information from the previous slide. That's our year-to-date actual information for our same revenue and expenditure categories. And then we've added in a projected column. And so the projected column is anticipated activity for the remainder of 2025. So that's September, October, November, December. And then the projected total is what we anticipate we're going to end up with at the end of 2025. And then projected variance is the difference between our budget and what we anticipate that we'll be at for the end of 2025. So if that's okay, I will move down through our revenue and expenditures and talk through where we anticipate we're going to differ from our budget. So at El Paso County funding is a set amount that we're allocated annually. We recognize that monthly, so we anticipate no changes to that revenue source. Similarly to state LPHA funding, as of right now, we anticipate that will come in as budgeted for 2025. For our program-specific grants, we do anticipate being under our budgeted revenue cumulatively through the end of the year by about $600,000. And that is a variety of different impacts from a variety of grants, but mainly we're just not utilizing one of our large grants, our CDC 81, for 2025 as planned, but those funds can carry over, so we'll be able to utilize those in future years. Our licenses, fees, and permits revenue is expected to be over what we budgeted, and that has been trending. We've talked about that in prior meetings. But that's mainly a result of environmental health fee increases being recognized and process improvements. Our Medicaid fees and insurance is anticipated to be over by about $40,000 from what we budgeted. And our interest income is projected to be under, which we've also talked about in prior meetings. And then our contributions and donations and miscellaneous is a very small portion of our revenue budget, but that also is anticipated to be a little bit under what we budgeted. Happy to pause for any questions.
Yeah, are there any questions on that portion? You can always ask them at the end, too.
Okay.
And
yeah.
before we move on, I'd like to just add, we did receive notice of a reduction to state LPHA funding based on the state's budget and adjustments that were made. The reason we have not yet adjusted that state LPHA funding revenue line is we don't know yet what the implementation of that will look like. So we may see that move down, but we're waiting for more information before we adjust that line. So there could be an adjustment there. There's likely to be an adjustment there moving forward.
Dr. Vu.
No, thank you. This is very helpful. In addition to this, because I've been so used to looking at the previous slide, can you also include a column on this slide to include the budget up to date, i.e. the first column of the previous slide onto this slide?
Okay, so the trended budget, so that's kind of like a cumulative of prior year data, is like a average for the current year budget, but you like that presentation?
The first column of the previous slide?
Yes.
Yes.
Okay.
That'll help me a little bit more. Thank you. I'm trying to compare the, thank you.
Oh, yeah, Commissioner Nelson.
You mentioned that the CCA1 grant is not being used, but those funds can carry over. Can you just speak a little bit to that and, yeah, just give us a little more context.
So hopefully I use the right words, but we are authorized to utilize those funds through 2027.
Okay.
And there are priorities that we have to meet within that grant. And we just anticipated utilizing more of those funds for 2025 than we ended up needing.
Oh, okay. Got it. So it's not that we're not using the grant at all. It's just not the costs didn't match up to what we were budgeting. Got it.
Exactly.
Okay.
Yeah.
What does CCA stand for?
CDC, I'm sorry, CDC A1 infrastructure.
This is
Okay.
federal funding and known as the Public Health Infrastructure Grant. So this is a multi-year federal grant that we were able to receive directly from Centers for Disease Control based on population size. And this funding goes through 2027.
Okay, and so infrastructure, is that then more towards capital type situation, or?
No, actually, more towards staffing, and we have the opportunity to use it for staffing. We have the opportunity to use it for professional development and contractual services to support public health.
Okay, great. And yeah, I mean, with staffing on grants, this can always be a challenge because then you don't have that sustainability necessarily. So thank you.
Mm-hmm.
And did you want to add something before Commissioner Dutner's question? Go ahead, Commissioner Dutner.
I just actually wanted to follow up on that I was pleased to see that we're not utilizing that at such a rapid rate because I was concerned we were going to draw down on that before the end of 27. So I think that is a credit to the work that you're doing. Thank you.
Dr. Jan.
I think I have the same question that I had last month in terms of the state and federal funding, or the program-specific grants, or the state funding. And that is, there are many things within the federal and state government that are somewhat fluid. And what we're doing is relying on those monies to flow this way. In terms of forecasting, are you quite certain that those funds are going to be there and that there's not going to be changes that will reduce the available funds to our budget?
So we are operating under contracts, so notices of award and contractual agreements authorizing us to utilize the funds. I think there's been discussion about what it might look like to cancel an agreement. I wouldn't want to speak to, but that's what we're operating under the assumption of, is this is authorized funding.
And so for most of these contracts, my understanding is that that the funds are used as they're used. They're not given in a lump sum, and then you draw down on that. They are given on, say, a month-to-month basis based on what is used. Is that correct?
Correct. So most of our grants, or all of our grants, are reimbursement based. So we spend the funds and then request reimbursement.
The exception to that would be the state LPHA funding, which comes in even disbursements throughout the year instead of a reimbursement-based invoice.
And so you are not projecting that, even though these are under contract, you're not projecting that there's the possibility that these commitments might change?
I think, if I could speak to that, I think that is something that governmental public health is monitoring very closely right now, because this is part of the reason we've discussed delays with emergency preparedness and response funding, as well as our contracts coming forward in manners that we haven't seen previously, where we're receiving the state allocation and then later getting documentation of the federal, because the timing of these has been impacted. So we are seeing some things come through differently than we traditionally have. We stay in close communication with the state health department regarding delays or concerns for the funding not coming through. To date, we feel like what we bring forward has been well vetted before we bring it forward for a contract agreement, because the state is not releasing these contracts until they have the notice of award. Of course, things could evolve and change. That's part of the reason why we are trying to make good use of our federal grant moving forward, so that we are not burning quickly on that grant, also looking at sustainable public health structure. So I think, yes, there is concern that things are not coming forward in the manner that they may have in previous years, and we are doing our best to understand that and anticipate it. But as we have these conversations with the state health department, who is also in touch with the federal government, we are all in a learning environment at this time, as some of the traditional ways these contracts have come forward has altered. So it is, we are monitoring closely. We're trying to make well-informed understanding of our budget, but of course there's some unknowns as well.
Okay, and thank you for the tip-off. I'm going to look over here. Who is?
Just one more quick question, because you briefly touched on the LPHA funding. And I know you said you're waiting on implementation, but is that just a timing question that you're really, truly waiting on?
It's more of a timing question and how that will change the monthly disbursements. That change was made after the state fiscal year. So how they will adjust that disbursement going forward is not yet clear to us, if it's going to be more than an even disbursement, because they are backdating it to July, so there may be adjustments to it that are not just even monthly disbursement of that difference per month. So we're waiting for those kind of details.
Okay, so because it was a 15% cut
it
across
was
the board?
14.4%, which I believe, and Lauren, correct me if I'm wrong, that was around 260,000
Okay.
in a reduction in
So
the
it's
state
just a matter
LPHA
of
funding.
how much, it may not
it's a-
be off the top of that in particular because of the disbursements.
Yep, we're trying to understand what that will
Okay.
look like. But yes, we do anticipate that that will be reduced by that 14%, 14.4.
Thank you.
Dr. Vu.
So thank you, Lauren, for this presentation, and I wanted to express my appreciation to all of our staff here at Public Health. I look at this and I see how hard our staff works in this time of uncertainty and this budgetary projection and all that, and I just wanted to really express my appreciation to all of our staff here in Public Health. Thank you.
Well said, Dr. Vu, and I think Lauren still has to go through expenditures, though.
Well, good news. We are projecting that we're going to be underspent for both personnel and operating. And that's just continuing to evaluate our vacancies and consolidating positions and just being strategic about how we're spending our money for operating. But happy to go into background information further if you like more details.
And Lauren, would you please also review the fund reserve?
Yes, thank you.
estimates?
Yes, so for 2025, we had budgeted use of fund reserve or fund balance of $970,000 based on our anticipated revenues and expenditures. And with these adjustments in reductions of costs, we are expecting that we're only going to use about $100,000 of our fund balance. So that's a significant reduction of that reserve.
Yeah, very much. Any other questions, Commissioner Nelson?
I'm not seeing it. Where is the fund balance total? Up
Thank
there?
you. So it's the bottom line. It says net impact, and I'm happy to change that to
So
different
Is it
descriptor.
the actual $1 million and 48,820? Would that be? Because you said we were planning to use 970,000 and we're not anymore, right?
So if I could call your attention, so the revised budget, it's a gray column, the third column at the bottom says 970,000 in a negative. And then the projected total, same line, has 100,000, 106,000.
So what is the dollar amount we have in fund reserves?
So as of January 1, it was $7,281,233. So $7.3 million.
Which isn't on this slide,
Okay.
Lauren.
But I can add that information.
Yeah, I think that might be helpful.
Okay.
Thank you. And thanks for the work taking our feedback last time and making this for us more easily to understand. Appreciate it.
Yeah, go ahead,
So
Dr.
then
Vu.
that brings up a question that's been in my mind for a long time. So there's the personnel cost is under projected. Is that because we don't need our staff, or is it because we need to? Yeah. So that leads to the next question, right? Do we use the fund reserve to relieve some of the pressure?
And if I could try to respond to that. So personnel underspending that you are seeing here is in part, I think, related to Dr. Chan's earlier question about uncertainty in the budget and trying to be conservative related to sustainable expenses for public health. So as we move into conversations about the 2026 budget, we'll be talking about sustainability for the agency. So yes, we have reduced personnel expenditures in order to be more sustainable moving forward. Use of fund balance, and we'll go over this in our work session as well, but our fund reserve policy excludes the use of fund reserve for personnel, ongoing personnel costs. So we would not be able to fund personnel out of the fund reserve except for some very limited time-limited uses that we've talked about in the past. So really, we do have some thoughts about how to utilize the fund reserve, but those are going to be related more to one-time expenditures versus ongoing costs.
Okay, thank you, Deanne. So then my next question is, should we change that policy? Should we really exclude that, or should we not? Right now, in terms of sustainability over the next few years at least, the sustainability is good because we have a really good healthy fund balance above what we had planned for. While in this time of uncertainty, do we use some of that fund reserve to relieve some of the pressure? Right? I mean, we had planned for a healthy fund reserve, and our fund reserve is more healthy than we had planned for.
Could I ask, Lauren, what is the minimum we should have in that fund balance based on the gold standard? I can't remember what percentage it is, but
So the informal policy that the board had developed is 18 to 21% of unrestricted revenues.
and what is that dollar amount?
I'm sorry.
What would that be in dollars, 18 to 21%?
Well, so I'm sorry, I don't have that dollar,
Okay,
but we were
fine.
planning to be at 23% at the end of 2025 with the use of this $970,000. So
Okay.
we're well above what we need to be
Yeah.
per policy. But I can get the dollar amount.
Commissioner Geithner.
Thanks. I think that's an important discussion, but I think we're probably going to cover a lot of that in the budget workshop today. So I think maybe we could defer that question to later. I'll just say, as a general concept, I think utilizing reserves for personnel is only advisable when you know there's going to be a very brief dip. And I'm not sure that I'm not sure the landscape is only going to be a brief dip, because what we're seeing is fundamental changes at both the federal government and the state. Those are not going anywhere in the next few years. So my concern would be that we would be looking at doing that for multiple years, and at some point we're going to fall off that cliff because it wouldn't be sustainable. But I do think that we should have much more conversation about that in the budget work session.
I do agree with that. I just less than 30 seconds. So how close are we to that cliff? Right, that's the question.
And I know that Deanne and her staff are looking and reevaluating all the staff positions to make sure that they're efficient and effective, and they're trying to streamline. So I thank her and her staff for that, because I think that's important. We all want to be as lean as we can and be responsible stewards of the public's money that we've been entrusted to expend. And so I think that that's also commendable. Thank you.
Okay, and Mayor Dixon.
I have a different question. With a fund balance of $7.2 million and a projected interest of $217,000, are we basically getting as much as we can from interest?
So that is managed by the treasurer's office. Public health doesn't have any
Okay.
direction on how the funds are invested or that portfolio. But it's our interest income is not based on our fund balance. It's based on our cash and investments, which is a different number.
Different number? Okay.
And I can get that for you. I don't have it right now.
Okay. Yeah, I was just curious. To me, fund balance, I mean, even in our town, we're dumping money in the Colo Trust as much as we can to earn as much interest as we can. And it's made a significant difference, actually. So, yeah, I was just curious. So, thank you.
Thank you.
Any other questions? I don't see any hands up right now. Lauren, do you have anything else in this in your report this month?
No, thank you for being receptive to the change presentation, and welcome any additional feedback or thoughts on that.
Okay, yeah, I think generally board likes these changes. So thank you very much. And with that, we'll go on to item number 7, which is contract renewals, and there are 4 contracts on there. We won't have to vote on these. They're multi-year contracts, but I'll hand it over to Deanne to lead us through this.
Thank you. So we have these 4 contracts that follow a federal fiscal year. They are all in various stages of renewal, which is why we don't need to do a vote today. But given that we have many board members who were not here for the approval of these contracts, we wanted to use the renewal cycle as an opportunity to review these contracts with the board, answer questions regarding the programming we have, and just provide this update. All 4 of these contracts are within our Community Health Promotion Division. So our Division Director, Daisha Hudson, is here today to provide an overview of these 4 contracts.
Good morning, Daisha.
Good morning. So yes, I'm going to be going over 4 different contracts, the first of which is our Drug-Free Communities grant. This is a complementary grant to our Communities That Care program. Both of these grants focus on the Fountain Valley area, and that is a requirement of the grant is to have a designated community, and that's why it fit really well within our Communities That Care program. You can go to the next slide, please. Oh, I will click through these, sorry. We are in year 5 of a current 5-year funding cycle, as Deanne mentioned. We are going to receive the full amount of $125,000, and our deliverables will remain the same. Drug-Free Communities is an evidence-based program, and it's really designed to mobilize the community around issues that they're seeing in their specific community and around substance use prevention. And so our grant or our program has 2 different goals: to establish and strengthen collaboration among community stakeholders and organizations to address youth substance use. And then the second goal is to reduce substance use and misuse of prescription drugs and marijuana among youth and adults by addressing the factors that increase the risk of substance use and promoting the factors that minimize risk. Our intended program outcomes are increased coalition member capacity so that they can reduce substance use in Fountain, decrease access to illegal prescription medication, increased marijuana risk perception. I know we talked about that with the tobacco grant. Like, that's really important that, kids view marijuana as risky, because we're not going to be able to change behaviors until they feel it's risky. And then reduce substance use among youth and adults. So I just wanted to highlight some of the work that this program does. Here's the team in action. So the first picture is our Teen Action Board. You'll see here that they were at the Colorado Traffic Safety Summit. They were actually invited to present at this summit to highlight the work that they do and how they've formed around an issue. And the issue that they've really been interested in working around is substance use while driving, so impaired driving, especially marijuana use, which is why they were invited to the Traffic Safety Summit. It was well received. There were 300 people in the audience, and just love to hear from the youth and how they are impacting things like that in their community. And then the second picture is a picture of one of our DEA drug take-back days. CTC holds 2 events each year, one in October, one in April. And we've had 6 events and have collected over 1,000 pounds of unused prescription medication. So removing that from the community, removing that risk so kids are less likely to have access to that. Any questions about drug-free communities before I move on to the next contract?
Daisha, I have just a clarifying question.
Sure.
So the renewal cycle, year 5 of current 5-year funding cycle. So are we the 24-25 year? Is that year 5 or is it the 25-26?
We are entering year 5.
You were
so
entering
next
it.
year we'll start a new cycle, and it will be a competitive funding cycle.
Okay, that's what I wanted clarification on. Thank you.
Mm-hmm. Sure.
Since you're already in year 5 of 5, and your evaluation criteria are like these substances that were used in the past 30 days or perception of risk or harm, et cetera. Do you, and you report that every 2 years, do you have any data on whether this program has reduced the prevalence of substance use in youth?
Sure. So there is a requirement, and it was in your packet, that we have to provide some evaluation data that's typically collected through schools, and we are supposed to collect that through a certain number of schools in the community, and we've not been able to get that data. And so I don't know that we can speak to specifically like the long-term impacts that we're having because we don't have access to that data, but we are diligently, we're working with the school, we're working with our funder and our internal data and analytics team to see if we can come up with another innovative way to collect that information and to demonstrate that we are having an impact in the community. I mean, we can show the impact through our drug take-back days and some of these other, from our outputs, but without that data source, it's really difficult.
With the drug take-back days, I think we've had this discussion before, where during those take-back days, you do not categorize what drugs are actually collected, right? That
Correct.
you don't know that out of the 1,000 pounds that you collected, that 20% are potential drugs of abuse. You don't necessarily know what drugs are collected during those take-back days. They are generally expired or unused medications, right?
Sure. And that's correct. And we did follow up with law enforcement to see if that was something that we could do. And unfortunately, it's a safety concern. Just not wanting to kind of pilfer through all the medications. But, you know, I think what we do know is that is one way that kids access illegal prescription drugs. And so the hope is that we're contributing to reducing that risk by removing those from the home.
So the data that is reported in the schools, your endpoints, your measurements of impact, where's that data available? I mean, if you don't have access to it and you're part of the program, where does that data go?
Can I chime in? Sorry, go ahead.
I was just going to say that I think at the core of this is the youth risk survey. Healthy Kids Colorado was the baseline. However, participation in that has not been enough to result in the release of local data. And our medical director, Dr. Albanese, has also been working with this issue with our data analytics team. It's a priority for the Region 16 Opioid Council as well to understand youth data. But currently we do have a gap in collection on youth data related to risk and drug perception from that survey.
Yeah, if I could just add on that this program in our packet said we're dependent upon a survey that is put out by a separate organization. And that survey, my personal opinion, is highly invasive and asks children to divulge very personal information. And so I know a lot of school districts in the area backed away from requiring that survey to be given to their students. And so it asked a broad range of questions, so I think I'm glad to hear that you all are looking at a different mechanism to capture data, and that if we're going into schools and presenting, then, you know, at the end of that presentation, like a 2-question survey of, you know, what are your thoughts on marijuana, or, you know, like, we do need to be responsible for capturing that data ourselves rather than relying on an outside source that doesn't align with the values of most of our community and the questions that we're asking children to answer. So.
Did you want to reply to that? If not, then we have
I
a
was
couple
just
other
going to
questions.
say, I absolutely understand. And I think, when we applied for this funding, we had the data. And it was, it helped us get the grant. Didn't know that we would not continue to receive that data. And so, we're doing what we can to try to get that information. It is hard to survey schools, even after a presentation. I think, we have to get permissions and things like that. And so just making sure that we're doing everything correctly and with integrity, and getting permission from parents and things like that.
Okay. And Hunter?
Just a quick clarification on that point. So it's still not clear to me. It's a requirement. We're not doing it. Completely understand the reasons why. What are the implications for the funding? And should we be considering this as the new norm moving forward when this comes back to the board for another 4 or 5 year cycle this time next year?
So, unfortunately, the reality is that we may not be funded for another 5-year funding cycle if we can't produce some kind of data.
Okay.
And that's why we're trying really hard, working with the funder. There's a possibility we could gather data from a neighboring community, but that's still not going to be.
Yeah.
That's not what the funder has asked, and it's just one of our limitations. And
Okay, well, you're explaining
Okay.
what you're doing to try to resolve
thank you.
that.
Yeah.
I think Commissioner Geithner.
Yeah, I think this is actually a really great discussion because one of the things that I noted as I was reading through this grant is, as Deanne has mentioned, that the Opioid Council has put significant dollars in funding towards youth prevention. And actually, we just had a specific proposal out and awarded a specific proposal for informing teens and the entire community about the dangers of THC, particularly high potency THC, and its connection to opioid use. So I think a couple of things is, one, we should be very aware, and of course Deanne attends those meetings, Lauren and I both serve on that, but I think we really need to make sure that we are working together with the Opioid Council, because there is funding going into this exact issue already. And to Deanne's point, we have had multiple conversations about the data concerns. I understand those, would love to see, although I will say, self-reported data is incredibly unreliable. We all know that. But it may be the best method that we have, right? I mean, there's limitations to everything. At the same point, the Opioid Council is, to Deanne's point, looking at finding additional ways to get that data, and I think we just need to stay very close to them as much as possible on this. The reality is, and I think Lauren said it very well, but it's unfortunate, and I'm not going to dance around it. It's unfortunate that our state politicized something that could have been useful for all of us, but made it so egregious that parents were outraged by it. And so I think we need to work with the Opioid Council to develop that, because we're asking for the same thing over there as you guys need here. And so I think, especially in this world of limited funding and things that are coming down, that is the specific, those are the specific goals of the Opioid Council as well. So I really think that there's opportunity to find a way. I think we spent over maybe $1 million, $1.5 million on working with CSU to work on finding a solution to helping us get to this. So there is opportunity, and I just think we need to work very closely on how we can do that, and perhaps work on building trust with our community that really, felt that we should have been taking action to protect our kids. So I think that there's a lot of opportunity before we get to this next cycle.
Yeah, thank you. We will definitely. We've already had some preliminary meetings about tapping into that. So thank you.
I have one quick clarifying question, just in my own mind. This grant does not require us to use the Colorado Healthy Kids Survey, correct? It was just, that was a survey that with data available at the time that we went through the grant proposal. But if we found a different source, then in the future, they maybe would approve this grant again if we had a different source of data. Is that correct? It's not tied to that specific survey.
Yeah, so it's federal funding. Each
Okay.
state, each community is going to have different mechanisms, and
Yeah.
that just happened to be ours.
The one that we had available, I totally understand. Just wanted to make sure going forward that the grant wasn't tied in any way to that specific survey. So thank you.
Okay, Daisha, I think we're ready to go to the second
Great.
contract.
So the next contract is our maternal and child health contract. The actual contract name is the Title V Maternal and Child Health Services Block Grant to States program. This is another grant that we are entering year 5 of a current 5-year funding cycle. We are not expecting any changes to deliverables. However, we typically receive a notice of award for a full year of funding, the $615,272. However, due to the unpredictability of federal funds, the state has opted to award funding quarterly because that's how they receive their notices of award. I think in the past they'd felt pretty secure in providing local LPHAs with a notice of award for the full year, but now just wanting to be careful about what they're promising until they have their notice of award. So this first quarter, we are receiving $132,511. That's not, so we're going to receive 4 unequal payments to total $615,000. Because if you multiply that by 4, it's short of the total dollar amount. But they have received their next notice of award, and we've been told that we should expect our next quarterly payment, and we've been told that it will add up to half of the amount when we receive that next payment.
Okay, any questions on this one?
So this is tracked at the statewide level, not at the county level. Is that correct?
Tracked, what do you mean by that?
Like a measurement of access to care.
Yes, so the state has overarching measurements that we contribute to by implementing the work locally. And then the state's measurements funnel up into a national, there's national benchmarks for maternal and child health as well.
Okay. So, like, for example, the statewide measures and outcomes are access to care, described as like the percent of children with special health care needs who receive family-centered care. So is that something that only the state tracks, or do you collect that data locally, report it to the state, and the state reports it nationally?
So those are their benchmarks and their goals, and what they give to us are strategies to implement those goals. And so we're not necessarily measuring locally, but we're implementing evidence-based strategies that are passed down to us from the state. And then we report on the work, the strategies, the outputs that we're doing locally. And then they track that and send it up to the national database. Does that help?
Yep, thank you.
So, and we kind of just talked about it, but the goal of this grant is to implement evidence-based strategies that improve the health and well-being of the maternal and child health population. So this program focuses on women of reproductive age, children and youth, and then a large portion of this grant is focused on children and youth with special health care needs. And those are children that just aren't developing typically. Our two goals are to improve access to care and to support healthy childhood development. Our intended program outcomes are improved maternal health and well-being, increased healthy childhood outcomes, increasing linkage to supports and services, and engagement of community partners in evidence-based efforts. And then again, I just wanted to add, show our teams in action. In the left-hand picture, that is one of our nurses at a veteran drive-through resource fair for expectant mothers. Here she's giving out safe sleep resources, different baby essentials, but also, that linkage to other services. So giving information about other public health services, other services out in the community to help meet that mother's needs. In the second picture, this program provides a lot of training and support, and this training in particular was specific to caregiver health and well-being. And so they invited caregivers and community partners who are serving children and youth with special health care needs. They know that there's a lot of burnout, a lot of resources needed, and so they're providing education and a platform to for those caregivers and the community partners to share about their experiences and additional resources in the community to support one another. Any questions about maternal child health?
On some of these grants, do we have numbers of people served? Do we have that data? It might not apply to all of them, but some of them it might. But I was curious if we have the number of people served.
So, like, we can get the number of, like, sorry. So for this grant in particular, like, we could tell you the number of women of reproductive age in our community, the number of children, the number of people that are eligible, I guess, for these services. I do think, Jennifer?
And if I could just add, so depending on the program, that will look differently. In our direct service programs, like women, infants, and children that will be next, we can speak to the number of clients engaged because that's a direct service program.
Okay.
For maternal child health, a lot of the work they do is training and community resource based work. So instead of like individuals served, it may be trainings delivered or stakeholder meetings, a work that has occurred there. So depending on the program, the number served may look a little bit different. And certainly that is the most straightforward for some of our direct service programming.
Is that information that could be provided as part of these contracts?
We can work on providing more information that addresses
here's how many
that.
sessions we've provided, or here's how many people that have been served, or something like that.
Yes.
And we may be able to follow up with some of that information. I know that we do track like how many people attended our trainings, how many trainings we're having, how many interactions were at this veteran resource fair. I just don't have that number with me.
Okay, thank you.
Yeah.
Is the training and support for service providers?
It's for caregivers and community partners that serve that population.
Yeah, Commissioner Geithner.
Yeah, since you said that you could probably provide us with some, maybe after this meeting, you've mentioned the specific outputs that were required to measure up. So maybe those are the things that would be great for us to see.
Yeah, we can do that.
I just wanted to share with the board something I learned because I had reached out offline on this grant asking about the 4-to-3 match, and Deanne helped me understand that the non-federal funds are truly state provided, and there's nothing coming from our local El Paso Public Health General Fund to help fund this grant. And just as I'm thinking about the numbers that, it's $615,000 over 5 years, that's not really enough to pay for 4.3 FTE. But then if you factor in that extra 4-to-3 match of state revenue, is that covering the full costs of those FTE, or are we having to help cover?
Sure, I'd be happy to speak to that. So in order for Colorado to receive the maternal child health block grants, Colorado needs to match $3 to every $4 in federal funding. So at the state level, there is a required match that occurs for them to receive those funds. When they contract with us for service delivery under that MCH block grant, there is not a requirement at the local level for a match to that contracted funds. That match is required at the state level. We do have some staff on the infrastructure funding. So beyond this grant, we also have some splits that support the maternal child health program that are on that CDC infrastructure grant. And we'll talk a little bit more this afternoon about how we're utilizing that and what some of that looks like.
Okay, great. Thank you.
And Daisha, back over to you.
I did want to just point out that the 615 is for a whole year, not over the course of 5. I don't know if that's what you meant.
Yeah,
but-
no, I thought at the beginning of your presentation you said that it was chunked out in the years differently, and
I'm sorry.
I just
So
misunderstood.
This year is a little different. We're receiving
Okay.
quarterly payments.
I
But at the
I
end
might
of
have missed
the year,
that.
we'll total the 615.
Got it. Thank you.
Okay. Our next contract is the Special Supplemental Nutrition Program for Women, Infants, and Children, otherwise known as WIC. We are currently in year 2 of a 5-year funding cycle. We did see a funding reduction in this contract, but no changes to our deliverables. Those will remain the same. The reduction was due to further adjustments to the funding formula at the state level. I also did want to point out that in your packets, at the time, I think we were working with the information that we had. I think I had said that the majority of WIC would be funded through the contract, and then a portion of the program would be funded through our A2 workforce grant, which is supplemental to our A1. However, there's about $250,000, just shy of $250,000, that will also be supported by flexible agency dollars to make the program whole. So I just wanted to point that out because that was not in your packet. The goal of WIC is to provide nutrition education, supplemental food benefits, breastfeeding support, and community referrals to other needed services. The intended outcomes are healthier pregnancies and better infant and childhood health outcomes for families at nutritional risk. So WIC is a short-term intervention program, and it's really designed to provide that education that's going to influence lifetime nutrition and healthy behaviors. WIC's nutrition education and supplemental food packages are associated with better diet quality, essential nutrient consumption from iron, calcium, vitamins A and C, lower rates of iron deficiency, and healthier growth trajectories for our children. And then one point here at the bottom, in 2024, Colorado WIC infants born to mothers who participated in WIC during their pregnancy were 46% more likely to be a normal birth weight than Colorado WIC infants born to mothers who did not participate during pregnancy. So the mom joined after pregnancy once baby was born. So we saw better, more normal birth weight among mothers who were part of WIC during their pregnancy. On the right there these are all components of a typical WIC package. The food package. A child will receive up to $79 worth of food in their WIC package. A mother can receive anywhere from $115 to $127 worth of food in their package, and that's really depending on if they're pregnant, postpartum, breastfeeding, the nutritional needs of the mother at that time. So a mother and a 2-year-old would receive, let's just say, the $79 and the $115. Those packages are combined and loaded onto their eWIC card. They can go to the grocery store, and they don't see a dollar amount per se. So they see, I can get so many ounces of cereal. I can get 3 gallons of milk. The only dollar amount they see is for fresh fruits and vegetables. And so that's how the program works, and that it's meant to be supplemental. So if you think of $79 for a kid over the course of a month, I know I spend way more than that a week for my child. So it's truly meant to be supplemental, and these foods are nutritionally significant and provide those nutrients that are needed to support healthy growth. Any questions about the food package and how? And it's paired with there's an app, and so it really it's.
Yeah. And Daisha, just to make it really just state it plainly, foods that we consider junk foods are not eligible in this, right?
Correct.
Yeah, so
Only these
candy,
things.
that stuff.
They can
Soda.
tailor a package. So if the family would like to get yogurt in place of one of their gallons of milk, our WIC staff can help tailor the food package that way, but it's only for these things.
Okay, thanks.
Yep.
Any questions, Dr. Chan?
Is there any concern regarding displacement of cost, where if an individual would have normally been using, whatever other sources they have to purchase these nutritionally dense foods, and then are now using WIC to purchase that and then displace the money that they would have used to purchase foods that are less nutritionally dense, like junk foods?
Sure. I don't have anything with me right now, any data, but that's something we could look into and follow up with you on. I don't know about. I don't know if Melissa, you have. Yeah, we don't have that right now, but we could look into that.
Also, one sort of unrelated question in terms of the average monthly enrollment. So these are like monthly numbers per year. How long does somebody usually stay in the WIC program?
So children are eligible up to, through age 5. So if mom's pregnant, and has the baby, then she's eligible throughout her whole pregnancy and up to the child's through age 5. Do you want to speak to that a little bit more?
So in El Paso County, do they usually stay in for 5 years?
Melissa, this is our division manager for WIC, and she's going to be able to answer that better
Okay.
than I can.
Yeah, and I'm sorry I didn't hear the whole question, but to the previous point too about displacement, we don't have the data of food funds to other areas, but I would just emphasize that nutrition education is a really big part of the program. So ideally, we are teaching families how to purchase overall, including from WIC, from any other food resources, and then also how to healthily prepare those foods, any other, strategies, picky eating with toddlers, things like that. So I don't have the data on that displacement, but there are interventions to ideally make the entire diet quality for the whole family improved. So, and then to the second question, I'm sorry, can you repeat what it was?
How long do people who are enrolled in WIC typically stay in the program in El Paso County?
I can get back to you with that data. I'm not sure off the top of my head. They can enroll in pregnancy as soon as they know, and then up until the child is 5. We do track things like early terminations of the program, whether that also be because they moved, because they just they're no longer income eligible, the economic status of their family has changed, and things like that. I can see if we can figure out kind of how, if they're eligible for that entire time, how long do they stay?
In terms of the program, I know traditionally the primary concern was about low birth weight babies. And so, for neonates to be normal birth weight generally means that they have adequate nutrition. And then for children, infants, toddlers, and children up through age 5, also, I know that the traditional concern was, say, sort of failure to thrive or falling off the growth curve. But nowadays, one of the primary concerns with early childhood is obesity. And so is that one of the things that is measured in the WIC program?
Yes,
The rates
yeah.
of obesity for
Yes,
children?
Yeah. Some of it is self-report or based off of data that they're able to get from their doctors, but we also take height and weight in the clinic every year. And then the other kind of anthropometric we take is the hemoglobin, because iron deficiency anemia and iron deficiency in general is one of the other main concerns in the population.
Very good. And Commissioner Nelson.
I thought it was really interesting that 90% of these funds are towards education counseling, and only 10% is actually going towards the food benefit. Is that based on once people are educated, they're like, oh, okay, now I will go buy those things and I can do that myself? Or the need isn't there, that they're needing the funds to go purchase the food?
So that's like in an average appointment, we would spend about 90% of the time on assessment, nutrition education, breastfeeding support, and that 10% of time on the actual food benefit issuance. Food dollars do not come to the county. They're a separate pot of money not managed by us.
So this $3 million is strictly just us educating people? It's not.
The implementation of the program. Yep.
Got it. Okay.
Okay. Commissioner Geithner.
I'm just curious, looking at this, because obviously I know this is all set by the federal government, but there's a lot of conversations about the food pyramid changing and all kinds of things. Are you anticipating or hearing about any changes to this program at this point? Because I will just say, cereal is not a healthy food for kids. And so I just know that there's been a lot of conversations about processed food, and I wonder if we're hearing any changes.
So we do follow the current dietary guidelines for Americans, and the food package is determined by NASEM, so National Academy of Engineering and Medicine. And yes, all those regulations do come down from USDA. They just did some food package revisions, and there was public comment, kind of all of that process. I am not sure at this time what kind of changes they would be. And I should mention too, like, within these categories, there are also restrictions on the types of food. So, and that's determined at a state level. So food companies can actually kind of submit all of their offerings, and then state goes through looking at very specific nutrition criteria, making sure that the cereals do not exceed certain added sugar, saturated fat, things like that, and also ensure that they have enough of the things we're trying to get to, like iron, calcium, vitamins.
And when I was reviewing the food package, I think like Cheerios, Chex cereal, low sugar options. So it is, they do take that into
The
consideration.
good cereals. The good cereals. Yeah. The kind I didn't like when I was a kid.
Add a banana to it.
So how many appointments is your team having in a month?
In a month, I would have to get back to
or
you.
a week or whatever.
Last year, when we ran the numbers, it was over 60,000 contacts.
In the year?
Mm-hmm.
Okay.
And that was 60,000, right?
60,000.
Not 6, but 60.
Yes,
okay.
60,000.
Those were not unique, right? They were multiple times coming back for assistance,
yes.
right?
So the average family on WIC is going to be with us about every 3 months, touching base. We have appointments at that frequency. Sometimes a little more, a little less. If they do have a high nutrition risk factor, they'll also see a dietitian.
And then another point of clarification. So the funding, that $3 million, it does include the food package money, or it does
No,
not?
it does
not. Okay. That's a lot of money. I was just curious.
So how many families then? And if you need to get back to us later,
I
that's
can
fine.
get back to you. The unduplicated count last year was over 20,000. Our average monthly enrollment is around 14,700 right now.
What is
And those are individual, so it's not, we don't count by families, we count by
Okay.
individual.
what does unduplicated mean?
That is even if we see that family more than once, they're not counted more than once
Got
in
it.
that number. Unique,
Okay.
yes,
Got it.
thank you.
Okay, thank you.
Good answers.
And I will just say, I know that, this is a large sum of money, but we operate out of 3 different locations. So we've got our clinic here, we have our clinic in off of Fountain Boulevard at Valley High, and then our Public Health South Clinic. And we also have a number of registered dietitians that we are obligated to have on staff for high-risk nutrition counseling. We have breastfeeding experts as I'm going to highlight here in a minute, but a lot of specialized staff that are that we're required to have as part of this program to support moms and babies.
Commissioner Geithner.
Super quick question of when we get those numbers, do you have breakouts of military families by any chance?
We use a variety of kind of stand-in proxy measures. There's nothing in our system that we can check off. We have gotten data from state of things like families that use leave and earning statements of that LES to recertify, and that's a good way that we can kind of figure it out. So yes, we have those proxy measures. We don't have the exact number because that's not something we collect.
If you,
Yes.
yeah, if you can include that when you provide that additional information, I'd be curious.
Yeah, and we also do have a mobile clinic on Fort Carson Army Community Service, so a really great partnership with them, and we have an educator there doing full WIC appointments and full WIC services to really support those military families.
Thank you.
I'd like to thank you for all of this information. It's very, very helpful. And if it's a $3 million program and you're seeing 60,000 visits a year, that's $50 a visit, which I think is very cost effective in imparting nutritional information and helping people make the right choices. Also, if you're seeing 20,000 unduplicated individuals, that's only $150 per person per year. And so I think that you're doing an excellent job of using these funds wisely and setting people up for a successful nutritional life.
Any other questions before Melissa gets to have her take her seat again? And I'll echo Dr. Chan's comments there. Like, great information for us, Melissa, and we really appreciate it. Yeah. Daisha, I think you have one more.
And just one more slide for WIC. I want to have your attention on the graph here. So, WIC, the dotted line is the state, the solid line is El Paso County, and El Paso County, our local WIC program is really excited to see that we've steadily stayed above the state average in exclusive breastfeeding at 3 months and at 6 months, and we've actually seen increases since 2019. So I think, a lot of kudos to our program. We know that research indicates that breastfeeding can reduce childhood obesity, which is something that we're obviously concerned about. It protects infants from things such as asthma, eczema, diabetes, tooth decay, and even leukemia. Breastfeeding can protect mothers from diabetes as well as high blood pressure and breast and ovarian cancers. So just wanted to highlight the numbers here in El Paso County and how we are trending slightly above the state, and we're really proud of that. Go ahead.
All of this makes sense, and Dr. Albanese, I was curious. The leukemia doesn't make sense to me. Do you know the pathophysiology of that? Breastfeeding can reduce the risk of leukemia in babies. I'm just curious.
Yeah, no, I have to be official and come to the mic. Bernadette Albanese, co-medical director. I do not offhand, and I think that would, my hunch is I don't want to speak out of tune here, but it's possible that some of that data is comparing children with leukemia and children without leukemia and their rates of WIC usage. I mean, it may be sort of an epidemiologic observation. Otherwise, I'm not a cancer doc, and so it's hard to. And leukemia, I mean, just like any blood cancers, takes on lots of shapes and sizes in any population, including pediatrics. And so, to look into that a little bit more. But I think the tooth decay and the hypersensitivity disorders like asthma and eczema and diabetes, just from weight control, I think are a little more evident. Yeah, good question though.
No, thank you.
Yeah,
Thank you.
Try to get some information on that. So the final contract is our WIC breastfeeding peer counselor program, and this is a component of our WIC program, but it's funded on its own. And this is, essentially, as it's titled, a peer counselor program. So mothers that are breastfeeding are paired up with a peer who has, had real life experience. They've breastfed their own children, and so helping that mother when she's struggling or not getting baby to latch or things like that. So someone that you can talk through those challenges with breastfeeding in real time. We are in year 4 of a current 5-year funding cycle. We did see a reduction in this funding, but that is due to, we were previously in a regional model, and we are now in an El Paso County only model, which reduced our funding. And the goal of the peer program is to increase prevalence of infants ever breastfed, and increase prevalence of exclusive breastfeeding, and increase duration of breastfeeding for clients participating in WIC. I did want to highlight that we recently received, our WIC program recently received the Premier Award for the USDA's Breastfeeding Award of Excellence. We were one of only 2 agencies in the state who received this award, and one of only 56 agencies in the nation to receive the award. And I really think that speaks to our high caliber of staff who are highly trained to provide breastfeeding support. We have several IBCLCs. I can't remember, IBCLC. So International Board Certified in Lactation. I knew once I said it, I wasn't going to be able to tell you what that meant. But it's, it takes a lot of training. They have to sit for an exam to become an IBCLC. And so that we have so many on staff is really wonderful and a great resource for our community. And that concludes my portion for the contracts.
Okay, looks like we have a few questions right here.
So I think that this is such an important program, so thank you. One question I have is interesting that we have a bit of a dip on the exclusive at 1 week, which is interesting to me, and I wonder if you guys have are you getting feedback from clients that are being served to say, like, what that might indicate why that is happening at this point, is that decline at 1 week?
Yeah. Melissa and I had chatted about that because I kind of had the same thought, and I know, and I'll let Melissa speak to it, but I think at 1 week, moms are still trying to figure out breastfeeding. They might be supplementing, so they may not be exclusively breastfeeding yet as they're trying to get breastfeeding established. Did you want to speak to that?
Yeah, we don't necessarily have hard data on this. I would say anecdotally, there is sometimes impact from hospital practices or that first pediatrician appointment, or kind of a wide variety of things, different health conditions, whatnot. So, yeah.
But, and I understand that, it just seems like that has been consistent, right? Like,
yes.
Over time, those things, I don't think like the practices around hospitalization or early pediatric appointments. I remember very specifically my oldest child being released, and they wanted me back. We left at 3 o'clock in the afternoon. They want you back at like 8 o'clock the next morning. So, I mean, you're just, crazy time when you're especially a first-time mom.
Yes.
But those things have been consistent over time, but this drop is just more recent. And so that's what I was wondering if there was anything that, and it could just be, it's a, somewhat small drop. It could just be an anomaly in the data, but you're not seeing anything that has changed in hospital practices or any cultural changes or anything that you would attribute to that. Maybe it's going to just go right back up.
I don't think in the past. I would say moving forward, kind of focusing, we already do some focus on our last prenatal appointment. We do some breastfeeding education that's really well evidence-based. We are kind of hearing from the community that not all of our hospitals are going to be baby-friendly moving forward, and that's not a certification that we are involved with. We don't know anything for sure, but if that is the case, then we will plan to adjust to make sure that parents really have that support and can advocate for themselves kind of in those really early days with regards to supplementation necessity and whatnot.
Okay, that is definitely, I could see that the change in practice in the hospitals could make a huge difference, because I certainly know that there were, my experiences were that had a huge impact.
And I
There's a
don't
lot
know
of pressure.
that has happened yet. So that's what I'm saying. Like, I don't think that's necessarily the reason for that past data. Is definitely something we are looking at moving forward.
Okay, thank you.
Hunter.
You took my question, but I'll just expand upon it. So I was actually interested to understand what causes the drop from 1 to 3 to 6 months, and what are you doing to try to not have that drop? And again, I should have led with, this is an incredible program. I've seen firsthand, over 3 children, just how rewarding this is for my wife, and not everyone can do it. So thank you for everyone participating in this program to make it happen. But yeah, just wanted to understand, what's the drop off? What are you doing to try to minimize that?
Yeah, is it okay if I speak to that?
Yeah,
Yes, I think it's very multifaceted, right? Like you just mentioned, breastfeeding is difficult, and making sure that all of our clients have that really large support, not only through us, but with the community, culturally, kind of all of that. Early return to work and school can be a big impact for really everyone, but especially our clientele. So yes, I think there is many reasons why we see that drop off. Just lots of different barriers might be going on. What we're doing is lots of adjustments to our program based off evidence-based, really. So as new research coming out, making sure our clients know, we have what's called breastfeeding ASAP appointments. So even if their next week appointment isn't until the next week, if they get discharged from the hospital, they suddenly are like, I really need support, they can get an appointment with us within 24 hours. I'm seeing lactation consultants. We have a lot more lactation consultants on staff and counselors than we used to. So just kind of making sure that we're adjusting where we need to really make sure that we're cognizant of what's going on in the community, the gaps in the community, and where we can fill in most effectively.
Great. One more quick
Yeah.
question, and then I'll be done. Do you know, is there a difference between, and I think we were starting to get into this, what the results are for first-time moms versus multiple births?
That's a really good question. I don't know. We don't have that data offhand. I can see if that's I don't know that we would have that data within WIC, but there is probably some data. But yes, it's something we take into account, but don't fully adjust program just because every mom's different, every baby's different, every mom-baby dyad is different. So even if they had a certain experience with their first, does not necessarily mean it's going to go that way for their second, third, fourth. So really just making sure that we're tailoring the support to that person and not just where they're falling in their
If you
journey.
can, I would like to see that.
Yeah.
I'm wondering if these numbers drop off after the first one because you have such a big focus and it's your first, and if that could lead to areas of opportunity for improvement and just better focus. So I'm just curious if you have it. If not, it's okay.
I can see if we have
Yeah,
that.
thank you.
Thank you.
Dr. Vu.
Oh, go ahead, Dr.
Oh,
Can I clarify my understanding in terms of exclusivity in breastfeeding? I'm assuming that exclusivity in breastfeeding is in the setting of adequate nutrition, because in my mind, adequate nutrition is higher in priority than exclusivity in breastfeeding.
Yeah, so these numbers, exclusive breastfeeding, would be they are getting nothing but breast milk until that 6-month mark. If we were to have someone that was supplementing with formula, then they would not be included in this data. But that being said, yes, absolutely. We are very cognizant to the fact that not everyone can breastfeed, not everyone's going to choose to breastfeed, lots of different health conditions. We give evidence-based information, but ultimately will support the family in whatever it is that they need. Also, in correspondence with sometimes their pediatrician, other medical providers, kind of using that specialized thing to make sure that their baby is growing adequately.
Thank you.
Yeah.
I'll address the last question first and then go backwards. So one of the important parts of the WIC program is just measuring growth, height, weight, and head circumference. And so if an infant is falling off in their weight, which in terms of baby growth, unless there's some other global underlying medical condition, weight will come first, and if something's going to drop off. And so if there's a trend in the weight percentile, and some of that may be investigated as struggling with breastfeeding, then it's not going to just be ignored and saying, well, you must continue breastfeeding. No, your baby must eat and grow. That is best. Yeah. Getting back to the other questions. So, yes, we can look at breastfeeding behavior from other maternal surveys that are conducted in the state. There's two other surveys that are done among persons who have recently delivered and then carried on forward. So yeah, that should be able to stratify that, meaning break it down by sort of how many children. I believe that's a question on there as a way to do that. And then just getting back to so one of the big reasons for drop-offs at 1 month is needing to go back to work. And now you're getting into a sort of determinants of health type of discussion in terms of the need for a new mom to go back to work to support whatever it is in the household with others in the household. And so thinking about policy things, breastfeeding friendly workplaces matter. They matter here. They matter out in our community. And so these are the things, if you this is a direct service that we're providing for our families in terms of one-on-one. There's absolutely no doubt that the one-on-one counseling of especially a new breastfeeding mom who hasn't had that experience before is critical. Having sort of the urgent help me is critical. And all the other sort of side effects that you can have with breastfeeding in terms of your engorgement and pain and that kind of other discomforts. However, a mom going back to, so first of all, time off of work is important for new moms and new families. And then if, a mom's going to go back to a unfriendly setting in terms of breastfeeding, that's gonna tank it when you have to weigh, quite frankly, right, when you have to weigh the need for the financial support with what the workplace is. And so when we find opportunities, and for this board and for our agencies find opportunities to promote breastfeeding-friendly workplaces, which is kind of like a private room and, a way to wash your equipment, that's all it is, we'll try to support that because that is a big reason for the drop-off, one of the big reasons for the drop-off.
Commissioner Nelson.
Can you speak a little? I'm just going to take this opportunity to learn more about the program and how it works. Are your staff going into the hospitals and meeting with the moms to let them know about the supports that you can provide, or what is the scope of it? Because there's only 1.25 FTE here, but your team has to be a lot bigger than that. So can you just give us a little bit more context of the program?
Yeah, so the 1.25 FTE as well is just the Breastfeeding Peer Counselor program. So the Breastfeeding Peer Counselor are the kind of educational messaging support and correspondence with moms. Often outside of the WIC office hours, though, I think that's really the strength of a program. So while we do not go into hospitals, in some, I'll do a second half of that question. But yes, we could be texting a mom after an hour after she gave birth, or if she texts in saying, hey, what do I do here? So we don't go into the hospitals, but we do have a really strong partnership with Ronald McDonald House. So we have an educator who's also a lactation counselor up there once a week, and so especially giving support to parents with babies in the NICU and around that breastfeeding support, pumping, kind of all of that type of stuff. She is there, so not in the hospital, but kind of at an adjacent organization, so to speak. But yes, there are remote also options to WIC now. So we do a lot of phone calls, and that clearly could be anywhere. And then we do have some community collaborative type of work. Once a year, we kind of gather different providers in the lactation space. So we are really collaborating rather than duplicating services and making sure we're all on the same page on certain different evidence-based practices.
Okay. I was just, this is really important work that you're doing. I remember hearing the phrase that breastfeeding is natural, but it doesn't necessarily come naturally.
Yes.
And so to have that support for mothers and the encouragement in a time when their world just got turned upside down and they're healing. And so I'm very grateful for what you're doing. And you made a comment that I didn't quite catch about hospitals not being, it sounded like you said baby friendly. What did you mean by that?
So, and this is outside of the WIC scope, so I'll just say that to preface it. There is a nationwide certification that is, it's called baby friendly, but it is for hospitals that have certain rigorous aspects of breastfeeding support, lactation training for labor and delivery nurses. There's a whole list of things. our understanding is that moving forward, some of our local hospital systems are not pursuing that certification. We do not know at this time the actual outcome of that, or if also the implications of that, if that's going to change their practices, or they're just no longer under this like certification program.
How does it work in combination with like insurance companies that maybe also can provide these kinds of services, but then, if someone's using Medicaid, I mean, do you have those sort of data points on socioeconomic use, and do you see a higher trend of certain populations that we're helping fill a need that maybe don't have the access? And
that's a good question. So WIC is an income eligible program, so we have very WIC specific data on that. Medicaid recently is now covering some lactation support as within the county. I am not sure exactly how many of our clients, for example, are also getting services elsewhere. Under WIC, we do not bill insurance. We can't because we are of the time and federal funding and things like that. Okay. But yes, there are some restrictions elsewhere of, maybe you had to give birth at that facility, or there might still be a fee for that facility, whereas we are free. We don't bill insurance. You can just, if you're on WIC, this is a service we provide.
Okay. So how did you say people learn about you?
About WIC?
Yeah, about like these supports that you're offering.
Yes. So ideally, if mom gets on during pregnancy, we are doing breastfeeding kind of discussions at multiple checkpoints. So our educators at paraprofessional level that are meeting with clients every 3 months are very open and transparent about what it is that we provide. And I should also say we do hospital medical grade breast pumps and things like that. So some overlap with Medicaid there in some regards. In other regards, no overlap because of the different things they can get and really kind of get into the weeds with breast pumps. But yes, we also sometimes put things out at community events and things like that, so people know.
Okay, thank you. Thanks for helping me learn more about the program. I realized I might have gone on a tangent.
Did you have a question,
Yes.
Dr. Chan?
Do you also collect data on partial breastfeeding?
Yes, I believe so. Yes. Like there are. And within our system, we categorize infants as partially breastfeeding, exclusive breastfeeding, because the partially breastfeeding infants would get formula support as well.
And is the formula also supported by WIC?
Yes.
Mm-hmm. Okay.
Okay. Courtney Salt.
Well, I love that we're having this huge discussion on breastfeeding. But I love learning all of this because I did not realize how deep this went. I was curious with the peer support, that's so important. And in your partnerships, do you partner with La Leche League and groups like that? Because maybe a mom doesn't need an IBCLC anymore, but the growing that peer support additionally, is that something?
Yeah, so and all the peers do not have advanced lactation credentials. That is part of the program to that exact point. You might tell your peer something very different than you're going to tell a healthcare provider. So informally, yes, I would say we can always make referrals, and we often do make referrals out into the community, either for advanced lactation help or for just hey, you might need a buddy at this point. So yes, we make people aware of what is out there, different support groups, or if someone has a request hey, I would really like a support group, then we kind of try to keep a list of what's going on in the community. And then, like I mentioned, once a year we do try to bring different community providers together so we can learn about what else is out there to make sure that we have the best knowledge to then help refer out to other community partners.
Thank you. I think this is a fantastic thing that we're doing, and I love that you're educating the benefits and providing the support because they're both so important. So thank you.
Thank you.
Okay. Doc, who wanted to add something? Please, Jack, come on up. Yes, you have to. And please identify yourself.
Yes.
Just say who you are.
My name is Margot Gray. I am an admin specialist, and I just wanted to add to your question you asked a couple times because I think it's important. I've been on WIC for many years with my children, and the way that I got onto WIC and found out about WIC, I worked for public health. I had no idea WIC was part of public health. Department of Human Services, that's part of the county, automatically sends referrals to WIC from every single person who applies. So obviously WIC is very much income-based. So anyone who is applying for Medicaid, for SNAP, for LEAP, for any sort of benefit, WIC is part of the DHS application automatically. So that captures a lot of people right there. For WIC, that's how I got on. So I just wanted to add that.
All right, thanks. And was there another question? I believe
Yeah,
Dr.
thank you.
Vu.
Just a brief comment. I think there's always a potential for a recipient to misuse funding. However, I think, personally, I think that should not be a barrier for us to continue to do the right things.
Okay, thank you, Dr. Vu. Are there any other questions? And, okay, well, Daisha, Melissa, thank you. I don't know if you'll come back up again, but thank you again. And Daisha, is that
Thank
it
you
for
so much.
you?
Yeah,
Okay.
that concludes my portion.
All right, great. That was very well done, real informative. I think the board got a lot out of it, and thanks again. And with that, I think we move on to item number 8, which is the director's report. So I'll hand it over to Deanne.
Yes, thank you. So for today's director's report, September is National Emergency Preparedness Awareness Month. So we have Janelle McNair, who oversees our Disease Prevention and Response Capabilities Division, to give an update about public health emergency preparedness and response.
Good morning. Thank you. My name is Janelle McNair, and I'm going to provide that overview of the program this morning, but I also want to acknowledge that I have Meredith Nichols here, who is one of the deputy directors at the Pikes Peak Regional Office of Emergency Management, and she's also going to be co-presenting a portion of this presentation with me today. Oh, and I have a clicker. Good. Okay. So I wanted to take an opportunity to share some background about the Emergency Preparedness and Response Program here at the Health Department. It does have a 23-year history, and it originated in the aftermath of 9/11 and the anthrax attacks. Both of those events spurred significant federal investment into public health infrastructure and building emergency response capabilities. So in 2002, this led to the establishment of the Public Health Emergency Preparedness, or FEP, program, and federal funding was administered through 5-year cooperative agreements by the CDC. El Paso County Public Health received this initial funding in 2002 and launched what was known as the El Paso County Public Health Bioterrorism Program. By the mid-2000s, however, and in the aftermath of Hurricane Katrina, there was a national shift in preparedness planning from a sole focus on terrorism to more of an all-hazards preparedness approach. Around this time, El Paso County Public Health was also designated as a Cities Readiness Initiative, or CRI, jurisdiction, which received additional funding through the CDC to plan for the rapid distribution of medical countermeasures during an emergency. Medical countermeasures are drugs, vaccines, medical devices, and other tools used to diagnose, prevent, protect against, or treat health effects. So by 2012, the program has really had really expanded its emergency support function 8 capabilities, which I'll talk about here in just a moment, and served as the health and medical lead for El Paso County during some major incidents such as the Waldo Canyon Fire, the Black Forest Fire, the Manitou floods, and the Planned Parenthood shooting. Then from 2017 to 2022, the program was engaged in significant disease response efforts during an extended hepatitis A outbreak, followed closely by a pandemic response. Today, our focus is on preparing and responding to emerging and re-emerging infectious diseases, as well as preparing to lead ESF8 activities with the Office of Emergency Management for identified hazards like wind-driven wildfires. So discussing this evolution of the program on a timeline is one thing, but I think seeing it in pictures brings a level of reality to it. While we may enjoy 300 days of sunshine each year, it's our readiness during the not-so-bright days that defines our strength and resilience within the community. Real incidents do impact our local community, and they certainly have impacted our local community. Wildfires, floods, active threats, power outages, and disease outbreaks.
So El Paso County Public Health plays a vital role in all of these emergencies, either as a lead or support agency, and must maintain a workforce that's always ready to respond. So spearheading preparedness and response activities here at the Health Department is the Emergency Preparedness and Response Team. It's a tenured and experienced team that also, I'm proud to say, has 4 members that are military veterans and consists of a division manager, 2 emergency management specialists, an administrative specialist, and our logistics support. This team leads preparedness activities here at the Health Department through initiatives of plan development, maintenance, revisions. Also, we build capability through trainings and exercises, and we engage in continuous quality improvement through after actions processes. All of these efforts combine to enable us to have a quick, coordinated response that's scalable and flexible to whatever situation that we may be dealing with. So, as a lead agency in an emergency response, this is typically defined by a combination of law, policy, jurisdiction, and the type of incident. Under statutory authority, El Paso County Public Health is designated to investigate and control the causes of epidemic or communicable diseases and conditions affecting public health. So when there's a situation that poses a widespread threat to community health, such as a disease outbreak, public health will lead the response. The scope of a public health response can vary quite significantly. It can last a few days for like a foodborne illness, or to several months or even years. Incident command is established as our standard for conducting incident response, and in times where we may need additional support or resources, the public health director can request support from the Emergency Coordination Center at the Office of Emergency Management. Some examples of our response efforts when serving as a lead agency include activation of our Department Operations Center, deployment of necessary supplies and equipment, and conducting disease response operations in and around the community. So in emergencies other than disease outbreaks or disease response, such as wildfires, active threats, power outages, El Paso County Public Health may be activated as a support agency by our Office of Emergency Management to serve as what is known Emergency Support Function 8. An emergency support function is a grouping of agencies, departments, and organizations by the type of assistance and expertise that they can provide during an emergency. Public Health is designated to serve as Emergency Support Function 8, which is the lead for coordinating public health and medical during an incident. As the ESF8 lead, the EPR team will coordinate with internal and external partners to provide the appropriate coordination and support during the incident. To hear more about our local emergency management structure and how emergency support functions support our response efforts within the jurisdiction, I'm going to turn it over to Meredith Nichols.
Good morning, everyone. My name is Meredith Nichols. I'm one of the deputy directors for Pikes Peak Regional OEM and have the privilege to work with Janelle and her team with OEPR. So if you're unfamiliar with PPR OEM and who we are a regional office of emergency management. An IGA created PPR OEM in 2019, and we serve unincorporated El Paso County and then also City of Colorado Springs, while also supporting our 8 municipalities in the county as well. We are a mission-driven organization, and so we support preparedness, response, recovery efforts throughout the Pikes Peak region. Our director reports to the mayor and then also our Board of County Commissioners. So as Janelle mentioned, we support and work with public health programmatically, really. But during an incident, emergency management really takes that consequence management, community stabilization side, where public health or law enforcement, fire, they would be managing the incident, putting the wet stuff on the hot stuff, or managing the flood, whatever, or a pandemic, or whatever the public health emergency is. We focus on the community side. So we look at sheltering operations, making sure our policy group's informed of what's going on, and then also how we can help our community recover from those disasters. And so this is our structure, what that looks like for our Emergency Coordination Center. And as Janelle said, we have a public health group in our ECC, Emergency Coordination Center, that focuses on our public health, but also behavioral health, environmental health, connection to our healthcare facilities, and also our EMS partners. And we have connections like we have with public health throughout these different emergency support functions. One thing to note, because we are a dynamic region, we need partnerships and connection to a lot of different partners throughout the region. And so the National Response Framework has 15 ESFs, emergency support functions. We have 28. And we have connection to our military. We also have a cybersecurity ESF. We have a higher education. And so we have a connection point and ability to coordinate with lead agencies, support agencies across our region to be able to respond to and recover from those emergencies. Really being able to integrate public health into our day-to-day operations. We have a liaison with the OEPR team, and with Jocelyn Rosado is our liaison, and work through some different planning initiatives, our advanced evacuation plan, to our integrated preparedness plan, which is a 3-year planning process that looks at trainings and exercises and plan development that we can build capabilities and help each other and our partners build capabilities to be able to respond and recover from disasters in a more unified, coordinated effort. I think we'll take any questions if there's anything, but I just want to say that, this connection and what we have with public health is awesome, and something that we've been able to build upon throughout my time here with El Paso County. It'll be 2 years in December, which is crazy to think, and so time flies. And so really great partnership that we have day to day, and then also during those bad days, be able to help support our community and make it stronger throughout the planning process. So. Okay, anything else?
We have a couple
Question.
more slides, and then we can take some questions.
Sure.
Thank you
Question
so
for
much,
PPR
Meredith.
OEM.
I think they're just going to finish
Yeah,
up,
I have
Todd.
2 more.
She's got 2 slides, and then we'll go to questions.
So I wanted to highlight, as a final thought of the overview of the Emergency Preparedness Response Program, a little bit about our national recognition. So since 2008, the Emergency Preparedness and Response Program has consistently maintained national recognition from the National Association of County and City Health Officials through what is known as Project Public Health Ready. This recognition enables us to demonstrate our commitment to preparedness by meeting rigorous national standards. They evaluate our all hazards response plans, our workforce training program, and our exercise response capabilities. And we are notably the only local public health agency in the state that has this recognition for our emergency preparedness and response program. So something that we continue to be really proud of. And then lastly, preparedness does not happen in a vacuum. Just want to leave you with that. Relationships and partnerships are a force multiplier when it comes to response. And El Paso County Public Health prioritizes these opportunities to engage across our community and enhance our readiness to respond to incidents that impact our local jurisdiction. As we know, it's not a matter of if, but when, and the cycle of preparedness never truly ends. Our EPR program and our agency stands ready, and we're driven by our agency mission to promote and protect public health and environmental quality across El Paso County through people, prevention, and partnerships. So that does conclude my presentation, and we're happy to take any questions that you might have.
Okay, thank you, Janelle, and I believe Mayor Dixon had a question.
Yes.
Yeah, it's more for PPR OEM. Obviously, communications are a key. And I thought I read something recently where something was discovered up in New York to try to overload communications. And so my question is basically, do we have backup communications that rely on totally independent sources?
It's a great question. I was reading those articles last night, actually. One of the things that we're looking at is building one, we have a special communications unit that is a volunteer group that we are able to have different communications to help with that kind of that bad day. We're also looking at kind of the after actions, lessons learned from those extremes where it's power outage, communication outage, things like that. And we're actually working on a workshop to look at a prolonged power outage that would have that impact communications, and see how we can work with our utility partners in all of those ESFs that you saw on the chart, and how we can respond and recover from that type of event.
Okay, thank you.
And other questions? If you ever want to talk about breastfeeding, we have a lot of questions for you.
Boy, howdy, what a group, yeah.
This maybe not.
Well, very important work.
Yeah.
Thank you very much
Yeah.
to both of you and your staffs.
Yeah, and if there aren't other questions, I'll echo that what you do is critical. We truly appreciate it, and thank you for that thorough presentation and with very few questions at the end. So, okay, thank you.
Thank you so much.
Oh,
Sorry.
there you go.
Since you're here, do you have just like one tip that you would leave with families as what good guidance would be for emergency preparedness in any kind of a
I
situation?
do actually. To just take time and talk together as a family about what you would do during an emergency, because really in the fog of chaos, that's you immediately think of your loved ones and how you're going to communicate. During an emergency, traditional communication lines could be down, to your point as well. So it's important to have backup plans. Meet your neighbors, know who you can go to for help and support if you need to evacuate out of your neighborhood, that you're looking out after each other, and that you take a sense of some personal preparedness as well. So knowing what the hazards are in our local jurisdiction and how you would react to that and what you would do if you were faced with a situation like that, I think can go a long way with just starting with a conversation.
And do we have guidance like that on your website?
we
Because,
do.
I mean, I don't even know how I would answer some of those questions to talk with my family.
We do. So we have our guidance on the Pikes Peak Regional Office of Emergency Management website, and on our El Paso County Public Health website, we link to that as well, as providing some general preparedness information for people. So I do encourage community members to go and look at those websites here at the Health Department and link over to the Office of Emergency Management. Also, to get signed up for peak alerts is another thing that we highly recommend, so that you can maintain that situational awareness and know what's going on around you. So,
Thank you so much.
Okay, thank you. And with that, our only item we have left now will be an executive session. But before all of you leave the room, I do want to thank Lauren from Finance and Daisha, Melissa, Janelle, Meredith for those presentations. You can tell by the discussion that the board really appreciated it. I thought it was excellent. And thank you very much for that today. And I want to thank the board members for all the good questions. With that, I'm going to really hand it over to Lori Sago to read us into executive session.
Thank you. Next on the agenda is an executive session pursuant to CRS 264402-4F for discussion of allocation of personnel resources. And so we would need a motion, a second, and a vote to approve going into executive session, please.
Okay. Could I have a motion to go into executive session?
Mayor Dixon, I'll move to approve. We go into executive session for the previously stated reasons.
And is there a second?
Second.
Okay. Lori, would you like to do the roll call to have us vote?
Yes, and I apologize if I get your name wrong, because
Oh, it's
reading
okay.
names off under pressure always makes me mess up. Dr. Vu,
Aye.
Mr. Barnett,
Aye.
Commissioner Geithner,
Aye.
Ms. Salt,
Aye.
Ms. Ralston,
Aye.
Councilman Donaldson,
Aye.
Dr. Chan,
Aye.
Mayor Dixon,
Aye.
Commissioner Nelson.
Aye.
Thank you.
Okay. And so for those who might be watching online, the only thing we'll do after this closed executive session is we'll come out of it and adjourn the meeting. So there really won't be anything after this. I think now we'll take about 10 minutes to prepare the room, and then we'll go into closed executive session.
Aren't we having a budget work session after the exec session?
That is,
After the exec session?
go ahead, Deanna, what would you like to say?
Yes, correct. After the exec session, we will adjourn our main meeting, and then we have an additional scheduled meeting, which is the work session.
Okay, I just wanted to clarify for the public that
Thank
there
you
is
for
additional-
clarifying that
Yeah.
for me, too. So, okay, so we do have that after the closed executive session. We will have a budget work session. Okay, thank you. And with that, I guess we'll have staff prepare the room. So 10 minutes.